to start recording. So I know we're going to take quiz 3 today. So if you tried to get on before now, it's not going to be available until the top of the hour, until 3 o'clock. So you might need to refresh, and it's not quite 3 o'clock yet. So it's only available starting at 3. So just FYI. Hi, Charisse. Okay. So welcome to week 5. Very hard to believe it's week 5 already. Very hard, but it is. So today we're going to cover concepts or do a review of concepts from weeks 4 and 5. Your quiz that you're going to take here in a minute covers concepts from week 4 and 5. You should have received your concept recordings in both weekends, right? Your week 4 concept recording, week 5, this past weekend. A couple of things since we last talked is I sent out the group assignments, right? Everybody saw those for your group project doing week 7. So hopefully somebody takes the lead and reaches out to the group and decide who wants to do what portions of the assignment. That is not due until the Sunday of week 7. So still have a couple more weeks to do that, but you do have your groups. What else? With the week 4 announcement, I sent out the study guide for exam 2. So you should have that. And that covers exam 2 will cover weeks 4, 5, and 6. So we'll do 4 and 5 today, and then next week will be week 6. And remember, next week, believe it or not, is already exam review week for exam 2. So you'll have the 3 live reviews next week. So have a look at the master calendar that was sent out and see if you can try and attend any of those live. It would certainly be helpful. And you definitely can see grade increases for students that attend the live reviews. And then speaking of exam 1, obviously you've seen the grades. Those were posted Friday night. For the majority, this class did very, very well. So congratulations. For the students that did not get a 78 or above, if you have not already reached out to me yet, please reach out to me with some times that we could meet to review exam 1 or review the concepts that you missed. I've already heard from some students, but I'm still waiting to hear from a few more. Okay. Does anybody have any questions?
Yeah, anybody who's in the group with me, Layla and Brittany, we have the Whooping Cough group. We had sent y'all an email if y'all haven't got it yet to see who wants to do what part.
I cannot find the email. I remember opening up and reading it, but I can't find it to respond back now.
I had actually just
send
got
it for-
access back to mine, so you might have to refresh it and reload because I just like this morning got her email and I was just responding to you, so I'm sorry.
Okay, I will double check. Thank you.
Okay, thank you.
Okay. Let's go ahead. I'm gonna make sure everybody's muted. Let's go ahead and start quiz 3. Everybody refresh if you tried to get into it before the top of the hour. The access code is, I'm going to put this in the chat. It's my last name. Okay, so go ahead and get started. It's a 15-minute time quiz. So let's come back at 3:05. Let's come back at 3:20. No later than 3:20. Take your time doing it. And then after that, we'll review the quiz in detail, do some concept teaching from the quiz, and then go back and cover all of the other areas of the concept that we didn't within the quiz. Okay? So everybody seeing the quiz? Okay. I'm going to go ahead and mute myself. Please stay on camera while you're taking the quiz, and after you submit it, feel free to go off camera until you have to come back at 3:20. Okay? If you have any questions, just put them in the chat, please. Okay, I think everybody's done. If you guys could come back onto camera, I'd appreciate it. How was it?
It wasn't too bad.
Okay. I think I told you at the beginning of the term, when I develop all my quizzes, I do it from the readings. Okay, so let's take a look. I'm gonna share my screen here. Did you see the rationales? Did you guys take the opportunity during the first couple of quizzes to go back and review the rationales as you were preparing for the exam?
Yes.
Were they helpful?
Yeah.
Good. Good. Okay, so most of these questions from this quiz come from week 4, which was special vulnerable populations, pregnant adolescents, LGBTQ, mental illness, alcohol, tobacco, and other drug problems. Okay, so you had a couple of full chapters to read where a lot of these questions came from, chapter 47 and 48 from your Med-Surg book. Okay, and then there were some questions from your fundamentals book, chapters 11 and 41. Okay, so the nurse is assessing a client who has PTSD. Which of the following would be an expected finding? Okay, what did you learn about when you read about PTSD? What do we know about PTSD?
It's triggered by previous event.
Yep. Yep. If you look in the rationale, PTSD is characterized by a previous event that involved some kind of threat, death, or serious injury to self or others, in which the individual experienced an intense fear and or helplessness and or horror, right? And so the triggering or the remembrance of such events produces feelings of intense distress, along with anxiety, maybe nightmares, flashbacks. Okay, and this is recurrent. Okay. And I have more to cover on mental illness, but we'll cover it after we do the quiz. Okay, this is a alcohol, tobacco, and other drug question. All right, so what do we know? Which statement can be applied to the blood alcohol concentration? First of all, sometimes there's confusion about how blood alcohol is evaluated. Okay, and one of the point of confusion is a lot of people think that blood alcohol concentration can be measured just by the amount you drink. Okay, and we know that's not true. Okay, what else is blood alcohol measured by?
Weight,
Urine.
gender,
The amount of fat to muscle, maybe?
what you've ate.
What you ate, last time you ate, metabolism rates, right? So it's multiple factors. But in this case, with this particular question, okay, we know that the liver can metabolize 0.25 of whiskey per hour. Okay. As far as A is incorrect, obviously B is incorrect, and D doesn't make any sense. Okay, and a little bit about alcohol abuse in your rationale. We know that alcohol abuse costs billions of dollars a year, and many things are affected: lost productivity, property damage, medical expenses from alcohol-related illnesses. from accidents caused by alcohol, it causes family disruptions, alcohol-related violence, and maybe even neglect or abuse or child abuse. Okay, we know that chronic alcohol abuse has multiple metabolic and physiological effects on all of the organs. People who use excessive amounts of alcohol may also not eat properly, eat an adequate diet, may develop vitamin deficiencies, other nutritional deficiencies. Okay, so we know the liver and pancreas may be affected as well. Okay. Alcohol is metabolized by the liver about 4 ounces of wine per hour, 0.25 ounces of liquor, 12 ounces of beer. Okay, that's why A is incorrect. It's 12 ounces. Okay, and then here's the answer to our question I just asked. Blood alcohol concentration is determined by several things. The concentration of the alcohol you drink, the rate of the drinking, rate of absorption, when's the last time you ate, slower in the presence of food, the rate of metabolism, and the person's weight and sex. So a lot of factors go into that. Okay. This is a mental, covering the mental illness concept. So you're preparing to care for a client with anxiety. What might you observe? Okay. We know that people with anxiety may have other mental health issues, such as depression or substance abuse. Okay, and we also know that a client with anxiety, it potentially impairs a person from functioning to their fullest extent. What do we know about anxiety? Let's look at the rationale. Anxiety is something that is expected. It happens in all of our lives all of the time, right? It's considered normal and healthy unless it becomes so debilitating that it impairs our ability to function in our everyday life responsibilities, decisions, choices. Abnormal or debilitating anxiety is intense, feels like life-threatening to us when we experience it. It's estimated that 30% of anxiety is inherited. Okay? So we're all at risk for anxiety disorders because of our physical, psychosocial, developmental, cultural, spiritual implications. We're all at risk. That's how we cope with it, or don't cope with it, right? And we also know that clients with anxiety often have other mental health issues, such as depression and substance abuse. I just said that. Okay, and we'll cover some other mental health diagnoses in a bit here. So now we're working with pregnant teens. Okay, when we read about pregnant teens, what are some of the big risk factors for pregnant teens? I'm just asking in general. What are some risk factors?
Is peer pressure one of them?
Peer pressure. Quitting school. Right? What else?
Depression,
Depression,
fear,
fear,
Environment.
violence,
Isolation.
violence, yes. Isolation. Yep. Yep. Right. So the question is, what are we going to focus on? Well, the nurse is working with pregnant teens. The focus for long-term should be which of the following. The correct answer from your readings is that we need to identify programs that will help them complete their education. Why? That's in the rationale. There's a direct correlation that exists between poverty and poor health outcomes. Okay, poor teens are nearly 3 times more likely to drop out of school than their non-poor counterparts. When we can assist in developing or giving teens resources, pardon me, like programs to assist the teens in completing their education, chances are increased for a better future for both the mom and for the baby across the lifespan. And it's equally as important to try and keep the pregnant adolescent in school during the pregnancy and try and have them return as soon as possible after birth. Okay, the more education that we can encourage for the pregnant adolescent translates into better decision making. Better decision making translates into better future for herself, for the baby. Okay. Okay, a culturally competent nurse leads an in-service for nurses on care of patients that are part of the LGBTQ population. So which statement by the nurse conveys the most accurate information about the acronym LGBTQIA? Because it encompasses a few things. Okay, the correct answer is C, right? This acronym is talking about both gender identity and sexual orientation. Okay, and that was right from your module reading. I took that question right from your module reading. And everybody understands what I mean about module reading. Okay, this rationale, as I was putting this together, really goes with both question 5 and question 6. Okay, so we can apply questions 5 rationale to the LGBT community, but we can also apply it when taking care of not just LGBTQ families, but homeless families, pregnant adolescent families. Okay, so this serves 2 purposes. Okay, so when we're taking care of LGBTQ families, right, we have an ethical obligation as nurses to provide culturally competent care. What is culturally competent care? What is it? What does it mean when you provide culturally competent care?
Is that being knowledgeable about the culture of the patients that you're treating?
Correct. Yep. And some nurses may have a degree of discomfort in caring for or in discussing sexual orientation or gender identity issues with their clients, right? But we as nurses need to overcome this barrier in caring for this population, right? We have to be able to provide a safe environment for clients to be able to discuss their sexual orientation. Most importantly, and this is a really important sentence right here, we need to initially understand what our own feelings and our own beliefs and maybe our own biases or prejudices may exist, may not. Okay, if they do, we have to understand and work through those feelings and barriers to be able to provide culturally competent care to this population. That is first and foremost. And this applies to this population, LGBTQ. This applies to homeless population. This applies to our most vulnerable populations, understanding our own feelings and providing care to these populations. Okay, clients with mental illnesses, clients with substance abuse, clients with drug addictions. These very special vulnerable populations require that we have to understand our own feelings towards everybody, towards all these populations, right? Right, before we can provide culturally competent care, right? So it's important to provide these clients, LGBT clients, with a safe environment, the impact of stereotyping, judgment, discrimination. Okay, we know that throughout the life of people that are part of the LGBTQ community, they often feel like they're being stereotyped or discriminated against. Okay, so we as nurses need to be aware of that. And then I thought this was a good part of the rationale that although social acceptance of LGBT people in the United States has been improving, and it has, right, they continue to face stigma and discrimination, right? Sometimes these negative experiences combined with the lack of access to culturally competent or culturally affirming care, right, result in disparities. Maybe lack of unfair access to resources, unfair being scrutinized, right? So we as nurses need to provide inclusive, high quality healthcare services to this LGBT community so that they can achieve their highest possible level of health, right? And I don't have much of a rationale for this because we just kind of reviewed it. What should be the initial consideration made by a nurse who's working with LGBT families, homeless families, pregnant teens? And there's your answer. We just talked about it. B, understanding of personal feelings, working with anybody that they will provide care to. As much as we like to think that we're all culturally competent, there may be some underlying thoughts or conclusions we've drawn, judgments we've made, right? And so the key is really understanding your own feelings. Okay, so that you are able to provide culturally competent care. Okay, alcohol withdrawal. What did you learn about that? Which intervention isn't? Hopefully you saw that word, isn't. So we're looking for a wrong answer. What isn't appropriate?
Yep. Maintaining that NPO status.
Yeah, why?
Because
wants to stay
food will help.
hydrated.
I'm sorry, go ahead.
I'm sorry. It will keep the, food and liquid will keep them hydrated. We want them to stay hydrated.
Right, right. So during alcohol withdrawals, clients may experience DTs, right? The nurse should always put the client's safety at the forefront, provide seizure precautions. Okay, this includes padding the side rails, ensuring intravenous access has been established, right, for hydration, like we just said. Oxygen is at the bedside, suction's available. Has anybody ever worked with clients going through alcohol withdrawal? It can be very scary. Okay, we want to do the other three: monitor vital signs, provide a safe environment, address hallucinations therapeutically if they're experiencing them. So all those other three answers are actually things that we would do. Okay, eating disorders. So we're assessing a client with a binge eating disorder. Nurse understands which other comorbidities are commonly found with this disorder. Well, we estimate that a percentage of these clients may have a family history of the binge eating disorder. And then very common is depression. Okay, so people with binge eating disorders may also have mental health problems such as depression, anxiety, suicidal thoughts, and may have a family history of the condition. Right? Some people with a binge eating disorder also have sleep disorders. Maybe have problems with their digestive system, maybe joint and muscle pain. Right? Okay, another alcohol abuse intoxication. Which of the following signs and symptoms of alcohol abuse intoxication would you expect to see? Right? Obviously, C and D, they're not going to have a steady gait and they're probably not going to be alert, right? So that's why A and B, the correct answers: drowsiness, slurred speech. So the signs and symptoms of alcohol intoxication can result in several things, several alterations. Person's consciousness, cognition, perception, judgment, affect, or behavior. All right, it varies depending on the severity of the intoxication. Right, not only the effects of alcohol, but also think of the complications caused by it. Maybe accidents, violence. These are all major threats to the individual's health. Right? Okay, and the last question gets into the week 5 concept of hospice care. All right, so the nurse is caring for a client with terminal disorder who's close to death. And reviewing the plan of care, what action is the priority? Do we all understand why B is correct?
Yes, ma'am.
This is hospice care. This is end of life care. Okay. A doesn't even make sense. C doesn't even make sense. All right. And D, we are actually carrying out the wishes of the individual, not so much the family, right? So in end of life care, the nurse needs to focus on the needs of the client, keep the client comfortable, and maintain dignity and self-esteem to the best of your ability. Okay, although we need to control pain, that's important in end of life, we don't want to keep the client so sedated that they're completely unaware of what's happening, right? We still want to have the client interact with family members to the best they can. And we want to try and have them participate in as many decisions as possible regarding their care, right? We know the family needs are important, but the client's needs are most important. Okay. All right. Does anybody have any questions about the quiz? Okay. I'd like to bring up our PowerPoint for week 4. Okay. So, special vulnerable populations, pregnant adolescents, LGBTQ, mental illness, alcohol, tobacco, and other drug problems. We just went through a lot of this, but I want to go through my teaching notes and make sure I've covered everything. Okay, so when we think of special vulnerable populations, right? We know, I'm reading from my notes as well, they have poorer health outcomes than their counterparts, correct? They have increase in morbidity, increase in mortality, morbidity and mortality. They have higher prevalence of chronic illnesses. These are our special vulnerable populations. Hypertension, high levels of communicable diseases, increased risk for TB, hepatitis, STDs, upper respiratory tract infections, right? They also have higher mortality rates than the general population due to some pretty common factors: poor living conditions, diet, health status, health access, high levels of crime and violence in their communities, including domestic violence. Okay, let's talk about the pregnant adolescents. What challenges, let's answer these questions. What challenges do pregnant teens face?
Depression, anxiety, isolation,
Okay,
Judgment, maybe, they're not treated fairly.
mhm.
Is scared.
What about late prenatal care?
Yeah.
Denial.
High blood pressure and low birth weight babies because of not getting proper prenatal care.
Yep. Late prenatal care, sure. Or no prenatal care. Yep. Yep. We talked about the correlation that exists between poverty of the pregnant teens and poor health outcomes. We talked about dropping out of school. Right? We know that racial and ethnic minority groups have higher rates of teen pregnancy, right? Because they have higher rates of poverty, lack of educational opportunities, higher rates of abuse and violence, right? One of the things that's common in teen pregnancies is domestic violence, right? What do you do if you're working with a pregnant adolescent and you sense or she verbalizes that there is some sort of violence going on in the relationship? What do you do?
We're mandated reporters.
Yes.
I
What
would
about us?
talk to her about her situation as well to see if we can get a little bit more detail. Like if she's safe, she could leave.
Exactly. That's where I was going to. Maybe establishing and putting together a safety plan, right? What might that safety plan include?
Well, I would want to know if she's living with the spouse that's
Mhm.
abusing her, or does she just go and see him? And if
Mhm.
she is living with him, is there another place that she can go to live?
Mhm. Mhm. What kinds of things would you want to in her safety plan? Would you want contact information,
Yes, ma'am. Referrals.
referrals?
Maybe referral to a shelter
Mhm.
for women who are abused.
What about important documents? Bag of clothes, what's her safety plan? Is she ready to go if she needs to leave? What would she need?
Birth
Okay.
certificate, her social, make sure she
Yeah.
has all important documents, her passport and stuff.
Mm-hmm. Mm-hmm. We talked about accommodations in schools for pregnant teens. Let's talk about the last bullet here, bonding with the baby. Let's say you're the home health nurse and she has delivered, okay? And you are the one doing a home health visit. Okay. What, especially for the teen adolescent new mom, what are you going to be observing? What is normal? What is not normal? What are you going to be looking for?
Is she propping the bottle up or is she feeding the baby laying down?
Mhm.
Does she smile when she's holding the baby? Does she
Yeah.
like seem to love it?
Mhm. Yep.
Is the baby clean and dry and have clean clothes on? Does the baby look, well taken care of? Stuff like that.
Yeah. Is she meeting the baby's needs? Right? Does she know why the baby's crying? Okay. And the other thing, when you are, let's say you're doing the postpartum visit, you have the opportunity to assess the whole environment, right? Is the environment clean? Is the environment chaotic? Is the environment loud? What if there are other people there? What are your observations as far as communication, as far as support? Does she have a support system? Right? There's lots of things to observe with a teen pregnant, a teen mom. Lots of things to observe. Okay. They're a very, very high risk group postpartum. Very high risk group. Okay. Um, okay. Our next is our LGBTQ. We talked about caring for LGBTQ families, understanding our own failings, providing a safe environment, and being non-judgmental. CDC, that's what I want to talk about. So we covered all of our notes on caring for the LGBT. The one thing we talked about was asking open-ended questions. We didn't talk about, but I want to talk about. When you're interviewing or trying to do an assessment, right? You can't assume heterosexuality, right? So if you ask questions like, are you married? All right, that may be a very hurtful. What might be another way to ask that? Instead of, are you married? What might you want to ask?
Do you have a significant other?
Yeah, do you have a partner? Right? So we have to be able to ask questions that don't assume heterosexuality. Do you have a partner? How should I refer to your partner? Right? We're not going to ask, are you married? Right? What is your relationship with your partner? Open-ended questions so they feel safe and like you're not being judged. One of the things with this community, with regards to the CDC, okay, they have recommendations for screening. Okay. Want to go through these recommendations with you. So the CDC provides recommendations on screening for prevention of sexually transmitted disease with this particular population. Okay, these are annual screenings and these are the recommendations. Write these down because you're going to need to know this. Okay. HIV, genital herpes, syphilis, gonorrhea, and chlamydia. Those are the 5 annual screenings that are recommended for this particular population when they're screening for the prevention of STDs. Okay, that's an annual recommendation. However, the recommendation can be bumped up to a more frequent screening, say 3 to 6 months, if a particular client in this population is higher risk. What do I mean by higher risk? 2 reasons. The individual has multiple or anonymous sex partners. Number 1. Number 2, they're using illicit drugs in conjunction with sex. Then the CDC's recommendation is bumped up to 3 to 6 months instead of annually. Okay? Let's talk about mental illness. We already went through anxiety. In your chapter, I think it's chapter 47, I want you to review. I want you to have a handle on what is the definition of general anxiety disorder. Okay? General anxiety disorder. A persistent, unrealistic, excessive worry about 2 or more life experiences or life circumstances for 6 months or longer. So have a definition of that's your definition of generalized anxiety disorder. I want you to know about phobias. Okay, excessive, irrational fear of something, a specific activity, a situation, an object. Okay, OCD is another one I want you to, and I just mean a couple sentences, just know what each of these mean. What does OCD mean? Obsession, recurrent, intrusive thoughts. You can't stop thinking about it. And then these thoughts create anxiety. We talked about PTSD. Another mental illness I want to address was suicidal ideations. When caring for somebody that's having suicidal thoughts or ideations, it's all about safety. Right? Do you have a plan? What is your plan? Do you have the means to carry out your plan? Have you attempted suicide before? Okay. Again, let's talk about kids for a minute. Kids are at the highest risk for mental disorders. Okay. They're at the highest risk for having disruptions, ongoing disruptions in their lives, whether it be their home life, their school life, their social life. Okay. The one medication I want you to be familiar with is lithium. Okay. Lithium goes along with bipolar disorder, right? A couple of important teaching points they're right on here on this. Know these teaching points. What do we do? Let's say we're instructing or educating a client who's taking lithium. We want to encourage normal salt intake. We want to report any diarrhea and report any vomiting, tremors, or lack of coordination. Okay. Okay, we've started to address this a little bit. Substance abuse contributes to teen pregnancies. Yes, we know that. It also contributes to sexually transmitted diseases, domestic violence, tobacco use, and what disease it contributes to. What are contributing factors to substance abuse? Why do people use drugs? Think about these. Think about all these questions. Okay. There's a couple of definitions that I would like for you to look up in your book that I definitely want you to know. Okay. These are them. Substance abuse. What's the difference between substance abuse, drug dependence? What's with withdrawal, detox? We talked a little bit about that. What's drug addiction? What's polysubstance abuse? What's alcoholism? Okay, so please be familiar with these terms. And here's some psychoactive drugs that are used with people with alcohol, tobacco, and other drug issues. Depressants. Make sure you can give an example. What's a depressant? What's a stimulant? We use energy drinks, nicotine, tobacco, vaping, e-cigarettes, alcohol, another drug, cocaine, another drug, amphetamines, methamphetamines. Nope. What are some community-based activities that we can be thinking about? Or here's an example of some community-based activities aimed at substance abuse. Maybe some school activities, student assistance programs, parental awareness. You're going to get asked about this on the next exam. These are some primary prevention strategies, right? Aimed at prevention. Maybe educating parents. I did when I worked in the schools. I did a lot of education, a lot of seminars, a lot of group meetings with parents. How do you become aware that what are the signs and symptoms your kid's using drugs? All right, so a lot of teaching and awareness to parents. Recreational activity involvement, after school clubs, sports teams. Encouraging parents not allowing drinking in their home. What are some anti-peer pressure skills? These are just suggestions. And then general screenings for alcohol, tobacco, and other drugs. That's what ATOD is. Okay, let's go back and talk about a couple of these. What do depressants do? Let's go back to this one. What do depressants do to your central nervous system?
They slow everything down.
Mm-hmm. Mm-hmm. What about vital signs? What's going to happen with your vital signs?
Increases?
Depressants
Well, you're-
decrease your heart rate.
Decrease your heart rate, decrease your blood
Decrease your
pressure.
Exactly. Decrease your muscle coordination, decrease your energy. Right? What about stimulants? What are they going to do to your central nervous system?
They're going to do the opposite. They're going to speed everything up.
Exactly.
Pulse.
Exactly. Yep. What about energy drinks? How do you teach high school kids about energy drinks that are all walking around with Red Bulls? What do you do?
Can mess with your heart.
It sure does.
Yeah, it sure
I've
does.
had that before, so I know.
Mm-hmm. Yep. Major cardiac effects. Right. What about nicotine and tobacco? How are you gonna teach about prevention? Well, let's say they've already started smoking. How are you gonna work with this group?
Maybe teach cessation through the gum. Would that be an
Mhm.
idea?
Well, that's sure. Sure. What about talking about long-term effects?
Like lung
Or-
cancer.
Yeah. 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 And then what about the vaping?
That's just as dangerous.
It's just as dangerous.
It's water
what?
going right in your lungs.
Exactly. Exactly. Yep. We talk quite a bit about alcohol. Amphetamines. What are amphetamines and methamphetamines going to do? What are they going to do to your mood?
Make you hyper.
Exactly. Elevation in mood, increased wakefulness, alertness, increased concentration, intensified physical performance, right? This euphoric feeling, right?
But they crash when they're on methamphetamines, don't they?
Pardon me?
They crash when they're on methamphetamines. They
Mhm, mhm,
crash for like 18 hours or more.
mhm. Okay, that's a lot to cover. Let's cover this week. Those are hard topics to cover. Substance abuse, alcoholism, mental disorders. But if you think about it in the big picture, if you're working in the community, you are going to be working with clients with these issues. Even if you're working inpatient in the acute care setting, right? You are going to be working with clients that have substance abuse issues, that have alcohol related issues, that have mental illnesses. You may even be working in a setting that works with adolescent pregnancy. So, these are very, very vulnerable populations. Let's shift gears and talk about this week: hospice and palliative care, death and dying, faith and spirituality, and ethics. Okay. What is hospice and palliative? Keeping patients comfortable, maintaining dignity and self-esteem, pain control, interacting with the family as well as the patient. Goal is to alleviate pain. All right, hospice, no cure, but improve the quality of life. Right? We want to try and humanize death as normal. Okay. What's the difference between hospice and palliative? That's the first thing. First question to you.
Well, hospice is treatment of a patient that has 6 months or less to live.
Exactly.
Palliative, it still deals with hospice, but I think it is more like the quality of life
Right.
that they have while they're in hospice.
Well, palliative care may start early on, right? Let's say they have a life-altering illness or a life-altering diagnosis. They're not quite in hospice yet. Okay, they may end up in hospice down the road. But palliative care is all of that care up to that point. And palliative care doesn't necessarily automatically mean you're going to be going into hospice care, right? My daughter-in-law, her dad was recently placed in palliative care because he has had some new diagnoses. They're not terminal diagnoses, had his colon removed for cancer, and then has had complication after complication after complication, and has all these life-altering things going on right now. Okay. And they felt like palliative care would be a good option. And the way they explained it, which is exactly how I explained it, it's trying to regain some control after life-altering things are going on. Symptom management, right? Including mental health support, physical support, psychosocial support, right? And trying to improve his quality of life, right? Trying to alleviate whatever suffering he has going on right now. There's no guarantee that he will eventually end up in hospice. He doesn't have a terminal diagnosis. So there is a difference. A lot of people just assume palliative care is the first step into hospice. Not necessarily. And as you can see from the slide, right, hospice then is really it says 6 months after all treatments are stopped, right? So there is a difference between the two of them. Okay. Stages of grief. Talk about that for a minute. When we're dealing with hospice, you are going to be working, if you're working in hospice, you not only have a client, but you have family, friends, other people involved. Okay. Everybody is going to be in a different stage of grief, right? Some may be denying it, some may be accepting it. Okay. So your stages: denial, anger, bargaining, depression, acceptance. Make sure you can give an example of a behavior. Let's talk about it. What are some examples of somebody who may be in denial?
Maybe you don't believe the diagnosis that the doctor gave you, and so you go and get a second opinion.
Yep. Or you don't want to talk about it. Right? And then that anger. I can't believe this is happening to me. I can't believe this is happening to my family member. What happens in the bargaining stage? I know you guys have studied the stages of grief. What's bargaining?
You might bargain with God, saying, God, if you just cure me of this, I'll go to church every Sunday.
Yeah, that's a great example. What else is an example of bargaining? A trade-off, right? If you do this, I'll do this. What about depression? When things finally settle in. You'll be dealing with family members that are all different stages. Right? What I want you to think about is, how do you help? How do you help family members? Maybe they're children. Maybe they're young children. Developmentally, young enough they can't wrap their heads around what's going on. Okay, so stages of grief are really important to consider if you're working in hospice, because with every client, you may be dealing with, including the client, all different stages of grief, right? Pain control. We certainly are not worried about addiction, right? But like we said in one of our quiz questions, yes, pain control is important, but we don't want to have them so knocked out that they have no clue what's going on either. One of the other goals in hospice is autonomy. Okay, we'll talk about that when we get to ethics. Okay, autonomy. Autonomy means having the ability to be involved in your own decision making for your own self-care or whatever your health care plan is. Okay, so yes, pain control is important, but we need to remember that autonomy is also important as well. We're not worried about addiction. We're okay with calling a doctor and saying, I don't, this doesn't seem to be helping with the pain. Can we prescribe more? Doing your own assessment, right? And then the use of pharmacological and non-pharmacological. Let's say you're a faith community nurse. You may be bringing in out in your congregation community, taking care of hospice clients. You may be bringing in the spiritual aspect, right? More non-traditional healing practices. That's what a faith community nurse does in hospice care, right? Make sure I covered this. That's the other thing with autonomy is we don't want to be making decisions for the clients, right? We want them to participate. I already said that, but I want to reiterate that the client in hospice is already exhibiting signs of loss, feeling loss of control, right? So we want to try and help them maintain any involvement that they possibly can with the decision making, right? When death becomes imminent, right? What we're going to observe, the client more time sleeping, appetites fading, oral intake falls, right? Urine output decreases, incontinence may be present, right? Usually your heart rate goes up, your blood pressure goes down, skin and extremities become cool and clammy, right? And then respirations are shallow and irregular, right? And the last thing I mentioned about hospice nursing is mentally draining, physically and mentally draining for the nurse. It's important for us to support our caregivers as well. Okay. And it also is important for us to understand our own attitudes and our own feelings with regards to end of life. All right, there's a lot of cultures that have very different beliefs about end of life care. Right? So if you're working with hospice, you need to be very clear on what the cultural beliefs, attitudes, practices are with regards to that culture regarding end of life care. Okay. Had a family member who was in hospice a couple of years ago, and part of the caretaking team was a culture that didn't believe in pain management at the end of life, right? The family believed in pain management, so they had to seek out alternative end of life care providers, because within the culture of caregivers, when it became imminent that pain control was going to be an issue. It was a cultural barrier for this culture. And so the whole care team had to be replaced because the family wanted the pain management, but the caregivers were unable to provide that based on their culture. It wasn't wrong. That was just their culture. Okay. One of the things we also talk about this week is faith and spirituality and culture. All right. We've talked about cultural competence, understanding our own culture and biases. Okay. And that's kind of similar to understanding our own feelings when we take care of homelessness, LGBTQ, pregnant adolescents, people with mental health issues. Okay. We have to understand our own culture and our own biases and how we take those, how we take those, our values, beliefs, practices into our care of other clients, right? We have to be able to see everybody is unique, right? There's no common minorities, right? Everybody is unique, all right? We have cultures that are focused, when you think about time orientation, certain cultures are focused on the past, certain cultures are focused on the present, certain cultures are focused on the future. And each one of those is okay. That's part of their cultural belief. But it also comes with some risks. All right. If you're past oriented, your culture's focused on what's happened in the past, sometimes that brings issues with planning for the future, right? Because you're so focused on the past, right? Right. And let's say you're a culture that is presently focused. Well, you're so focused on the present, what's happening today, that you fail to plan for what ifs, right? And then on the flip side, if you're so future focused, what's going to happen down the road, you tend to not pay attention to what's happening in the here and the now. It is what it is. Different cultures have different time beliefs. But you have to be aware of those when you're caring for those cultures. Right? So think about, like, here's an example of the thinks the Indian culture, the Native American culture, they're very, very past. That's just an example. They're very past focused. Okay. So if they're somebody who needs to plan ahead for, say, future visits, let's say they've had, I don't know, cardiac surgery. They need to plan for cardiac rehab, cardiac visits. They're going to need some assistance planning ahead because they don't think ahead. Does that make sense? Also, with regards to culture, right? I know that old saying is treat everybody like you want to be treated, but think about it, right? Our cultures, let's say the client you're caring for, the culture is so vastly different from ours that doesn't really apply. We want to be treated, like, treat every patient like you would want to be treated. Well, that's not necessarily true. Right? We as nurses must be culturally competent in caring for clients. Okay? Cultural competence. This is really important down here. I want you to know this. Cultural competence is attained when we, the nurse, are making conscious efforts and attempts to learn about people of diverse cultures, and we're looking at the world through their perspective. I can't stress that enough. Okay, there's a lot of ways we get there. All right, how do we learn about different cultures? Well, we can do our own research. We can ask our clients, right? We can observe. I'm sure you do this in the inpatient setting all the time with your clients that have family members. You're always observing what's going on, right? And you take those values and beliefs and attitudes and whatever their cultural needs are, and you do your best to try and incorporate those values, beliefs, practices into whatever the health plan is. Right? We touched a little bit on the faith community nurse. A lot of people don't know about faith community nurses. I have a couple of girlfriends back home in Colorado that are faith community nurses, and they have been for years. Okay, so there's another role as a community nurse. You know, we have the school nurse, the occupational nurse, the public health nurse. Well, we also have faith community nurse. Okay, this is a nurse that works within a faith-based community, whether they work, whether the faith-based is a church, whether it's a mosque, whether it's a temple, it doesn't matter. Okay, a faith-based community nurse is working with a congregation of a certain religion. Okay, and what they bring, and we touched upon this briefly, but what they bring is the spiritual aspect to the holistic care. Okay, they're much more community oriented than community based. So they are looking at they are looking at getting to know their congregation. What are the needs of their congregation? Do they have a high level of elderly, a high level of kids, a high level of new moms? What is their community makeup? Do they have a lot of chronic diseases? Do they have a lot of clients in hospice? All right, so they're really doing an assessment of their community, working with the congregation to find out what needs does the community, the faith community nurse need to provide. Okay, maybe they're doing support groups, maybe they're doing grief counseling, maybe they're doing visits to new moms. Right? So incorporating spirituality into their practice, focused on holistic mind, body, spirit. Does anybody know anybody who works in the faith-based community? No? Anybody that any of you belong to a parish or a congregation that has a faith-based nurse in their congregation? Oh, come on. Really?
Well, I know that we have nurses in the church,
Uh-huh.
but I never knew like what was behind it. They usually just helped congregation members who needed help after they maybe passed out or something. But I never knew like that they did anything other than
Yeah.
what they did there.
Yeah, they do a lot of education. They do a lot of screening. They do a lot of maybe home visits. It's whatever the congregation needs are. Whenever you do your assessment of your congregation, what are the needs? Do we need primary preventative activities? Do we need secondary intervention activities? Or tertiary, or maybe a combination of all of it? Okay. Ethics. What are ethics? Really important discussion here. What's ethics?
It's like a combination of moral and legal rules or laws.
Mhm.
I don't know how to put it
Yes,
into words.
but ethics is what is morally the right thing to do. Right? We have ethics involved in all of our daily lives.
Ethics is more like doing the right thing when no one
Doing
is
the right
looking.
thing. Oh, that's a good way to put it, when nobody's looking. Okay. What do we do? We are morally doing good. Okay. So there's a couple of ethical principles that we follow, not only in nursing, but in our daily lives. One is called beneficence. Okay, here's our ethical principles. Okay, I want you to know about beneficence. Beneficence, to do good. Okay, we do the most good possible within the circumstances. Okay, non-malfeasance, these are the ones I want you to know. Beneficence, non-malfeasance, do no harm. So I think it might be a quiz question, but here's an example. You're working on a floor, you're doing a catheterization, and you contaminate the sterile field. What do you do?
Reset the sterile
You keep
field.
going, or you go get a new kit?
Get a new
Go
kit.
get a new kit.
Right, because you don't want to do harm. That's an example of non-malfeasance. Distributive justice. Is this on here? I don't see distributive justice on here. Distributive justice, okay, is making sure everybody in your community has access to the same resources. Distributive, is it distributed among all of your community equally? And then we talked about autonomy, respecting the patient's rights to make decisions. Okay. And then moral distress. Where are my notes on moral distress? Moral distress is experienced when an individual, we all go through this, is unable to act accordingly with what we do believe to be the right course of action, right? We all experience this at one time or another as nurses or members of the community, right? In nursing, moral distress can lead to burnout. Let's say as simple as patient assignments, patient workloads, where we know we're being asked to do too much. You're in distress, moral distress. What do? You need to think about, can I provide safety to all these patients? What are the risks? Okay. Other examples of moral distress, maybe end of life decisions. Talked about patient loads too high. Remember during COVID with all those visitor restrictions, people weren't able to come in and see loved ones, whether they were sick or dying. Okay. Advocacy, that's another ethical principle. We as nurses are advocates for our clients. That's just a simple ethical principle. That's what we are as nurses. We're advocates. To do the best, provide the patient the best information, resources possible for them to make their decisions. We're advocating for them. Okay. Okay. Advocacy we talked about. Let's talk about a couple of, before I talk about American Nurses Association, a couple of examples of legal nursing issues with regards to ethics. Think about documentation. What is nursing documentation all about? Can you document, oh, that patient seems cranky this morning? Is that an appropriate documentation?
No, documentation for nurses are things that can be measured or seen. That'll be seen the same by anyone who's looking. Like your blood pressure is on 120/80, the temperature.
Factual.
Mm-hmm.
Factual. Okay, they're objective, not subjective. Okay, you don't know why the patient may be cranky this morning, right? And to document that's unjust. Okay, but if you're asking a patient on a scale of 1 to 10, where's your pain? It's a 5. That's factual. What are your vital signs? That's factual. Okay. Factual documentation, descriptive, objective information, what you see, what you hear, what you feel, what you smell. You can't use your subjective observations without supporting factual data.
Or how
Right?
they tolerated it.
Yes, yes, yes. Right? So the terms of he seems to be cranky, he appears to be cranky, right? Because that's really stating an opinion, right? So that's one legal aspect that we face as nurses. And the second one I want to bring up, because you're going to get asked about this, floating in different assignments, right? How do you handle floating? What would be a safe way to handle? Let's say you're asked to float to a different unit that you work on an adult unit and you're floating to a pediatric unit. What? How can you function safely on the pediatric unit?
You would probably need to work close with somebody who's used to that floor, somebody who already works on that floor.
Okay.
Maybe
So
send them to the least patient with the least risk, like maybe a child that needs their blood sugar or something taken, but not one that's came out of surgery or with trachs or
Exactly.
anything that would be complex like.
because we're going to be asked to float all the time. Okay, it is up to you with your license to be able to communicate, find that manager, find that director, find that head of that shift that day, right? And talk about what you can safely do. You know, I'm Janet. I've never been to this floor before. No, I can't do this, but I can do this. And I feel safe doing this. Right? Because technically, I mean, unless you have a union contract, I don't think you can refuse to float. Right? So best you protect yourself when you float by communicating ethically. I mean, you ethically have the responsibility to do good, do no harm. How do you accomplish that? Well, you have to communicate what you can do and what you can't do based on competency, not I don't want to, it's I don't feel safe. Right? And along those lines, the American Nurses Association, what is it? Okay, what is the American? We're all part of the American Nurses Association, right? We're all covered under the American Nurses Association, right? What are they? And what do they do? Okay, here's what they do. They formulate general, not specific, general standards and guidelines for nursing practice. Right? They apply to all of us, broad. They're general and broad. They apply to all nurses, not pediatric nurses, not OB nurses, not surgical nurses. They're general standards and guidelines. You're going to get asked about that. So know this slide. Okay. Okay. All right. So that is all the content for these 2 weeks. That's a lot of information. Do you feel a little bit more knowledge about each of the concepts? Do you have any questions?
Yes, ma'am. So that distributive justice that you talked about, I do have what you put down for us. Do you know if there's anything in the reading
Yeah, you
that'll let
have-
us?
You have
I haven't.
ethical, chapter 3.
Okay.
Chapter 3 in your fundamentals book, only a couple of pages, but it talks about it, is
Okay.
page 44 through 46 in your chapter 3, legal and ethical aspects of nursing. That's where those ethical principles come from.
Okay. Thank you.
Okay, does that help?
Yes, ma'am. A lot.
Okay. And then if you're having trouble, if you need a little more information, hospice and palliative care is an excellent reading embedded in your module about hospice and palliative care. I think I got that quiz question from that reading, about priorities. But that's a really good reading to get a good understanding of it. All right, make sure you know the stages of grief. Yeah, so I think we covered all my notes, my teaching notes. So a lot of information to cover. I know this is a heavy week. We covered a lot of concepts. So we've got 2 weeks down, weeks 4 and 5, and then next week we'll do week 6. And then if you come to, then during my review, I take your study guide. I've already kind of done some bullets in there of things I want you to know. If you watched my review from exam 1, you saw that. Okay, but I want you to do the legwork. Okay, and then let's see how similar we are when we get to the review. Does that make sense? So, questions? You got 3 minutes to spare. Gift of time. And then again, anyway, if you haven't reached out to me, if you got a below a 78 in the exam, reach out to me, please. And we'll schedule a tutoring session. Go ahead.
Can I
Sharice.
meet after? Okay.
Yep. Okay, well, it's Monday, so I hope you guys have a good rest of the week. Please reach out if you need anything, and we'll see you next week. Okay?
I'm sorry, I have a question real quick.
Yeah.
I have not been able to find the HESI review paper to be filling out. I've been
It's in
taking
week
notes,
1.
but